All of us are here today united by the belief that healthcare is a basic human right, and that using machine learning may allow us to provide better healthcare for ourselves, for our families, and for our friends. However, the path to using data to improve healthcare is fraught with difficulties. Before I begin with my main talk, I want to give you some sense of what these challenges are, using the experience of his son watching his mother die of cancer. My mother died about 8 months ago from multiple myeloma. My mom was diagnosed with multiple myeloma in March 2014. Multiple myeloma is the second most common cancer of the blood, with about 4 people per 100,000 diagnosed each year in the United States. It's a cancer of the plasma cells in the bone marrow. These plasma cells produce antibodies that play an important role in immune function. However, in multiple myeloma patients, these cells proliferate, leading to bone lesions, along with other complications. Until 2000, therapy options were very limited for patients with multiple myeloma. Patients could receive an autologous stem cell transplant, they could take steroids. However, the story changed dramatically in the early 2000s when several new drugs were approved by the FDA in the United States, beginning with Velcade in 2003. When my father and I went to the Multiple Myeloma Research Foundation patient conference later that month, the month that my mom was diagnosed with the disease, there was a feeling of optimism in the room. 3 new drugs were in phase 3 trials. 17 new drugs were in phase 1 and 2 trials. At the time when President Obama's precision medicine initiative was just forming stage, multiple myeloma was being heralded as one of the most promising targets for personalization of treatment strategy. Cytogenetics revealed that my mom had a T1114 translocation, which put her at, quote, standard risk as opposed to other translocations which are associated with more aggressive disease. Multiple myeloma is classified in terms of 3 types of increasing severity. MGUS, considered a precursor to multiple myeloma, asymptomatic or smoldering myeloma, and symptomatic myeloma. Because my mom had a plasma cell infiltration between 25 and 60%, but no evidence of hypercalcemia or bone lesions, she was classified as having smoldering multiple myeloma. The standard protocol for treating patients with smoldering multiple myeloma is to give bimonthly infusions of biphosphonates to strengthen their bones, but otherwise just to observe patients and only begin treatment once the disease appears to progress. I knew from attending that patient conference, however, that eventually my mom's disease would progress and she would need to begin treatment. But which treatment? A year and a half later, I turned my attention to studying multiple myeloma. My goal was to develop an algorithm that could predict response to treatment given what we know about the patient. I wanted to have it ready so that when my mom needed to make that decision of what should her first treatment be, I could give her some good suggestions. I spoke about how knowing that she had this T1114 translocation put her at standard risk, and about how the simple classification scheme labeled her as having smoldering multiple myeloma. These classifications have an enormous impact on patient care. For example, in my mother's case, it was the reason why she and her clinical team decided not to initiate treatment. The existing classifications and risk stratification algorithms were developed using very small data sets, where only a small number of covariates or features were considered for each patient. And because of the small sample sizes, only very simple, non-linear relationships were considered among the observed features. Imagine now that we had good data on tens of thousands of patients with this disease. We could use state-of-the-art machine learning algorithms to discover rare yet predictive features and complex nonlinear relationships that could give insights into the patient's disease stage, progression, and treatment targets. Unfortunately, obtaining such high-quality clinical data in abundance is difficult to impossible, making it much more difficult to apply the standard machine learning toolkit to these problems. We began our research by deriving a cohort of several hundred individuals with multiple myeloma. We worked with clinical data that included laboratory test results that we know to be very important for understanding the disease stage for this disease. However, working with this type of clinical data is incredibly challenging from a data science perspective. Before one can even think about applying machine learning to predict treatment effectiveness, one has to find the treatments in the data and characterize their statistical validity of attempting to assess treatment effects from observational data, taking into consideration the sample size and potentially confounding factors. The first challenge we grappled with was identifying treatment regimes and lines of therapy. Each treatment occurs over a period of time. For example, when the proteasome inhibitor Velcade is administered as a frontline therapy, it's typically given for 9 to 12 months, twice a week for 2 weeks, and then 10 days off. Other physicians might use a 1-a-week schedule. When it's given as a second-line therapy, it's given on specific days of a 21-day cycle, days 1, 4, 8, and 11, with up to 8 cycles being given. And of course, patient preferences and logistics might lead to variations on this theme. Dosing levels might also vary from patient to patient. Moreover, given the fast pace of drug development and research in myeloma, the treatments themselves have been changing dramatically in the last several years. So much of our initial work, before we could even do any machine learning, focused simply on identifying and grouping together treatment strategies, guided by the literature and by our clinical collaborations. Next, we had to tackle the problem of characterizing whether a patient reached a partial or full remission following the treatment. That is to say, just getting the outcome that we could use within our machine learning algorithms. This too is complex to derive from raw clinical data, requiring us to look at changes in biomarkers and other subtle hints, such as changes in treatment strategies, all of which, by the way, could have been confounded by other aspects of a patient's health, personal preference, and side effects. So this is just to say, applying AI in healthcare will not be easy. Ultimately, my mom died before she should even begin her first line of therapy. What actually happened to my mom made strikingly clear the importance of the second theme of my talk today. How can we develop artificial intelligence that can help us improve the coordination and delivery of healthcare? In March 2017, following seeing a cardiologist in New Jersey, where my parents lived half the year, my mother was admitted to the hospital where it was discovered that she had multiple pulmonary embolisms. She was put on anticoagulants, which eventually dissolved the clots, but she continued to suffer from shortness of breath, which prevented her from sleeping, and lack of appetite. From that point on, my mom was very weak. My parents were worried that the pulmonary embolisms might somehow be related to her myeloma. But her oncologist, who, by the way, is considered one of the world's best oncologists in this area, he assured her that it wasn't related to her disease. In subsequent weeks, my mom also had swelling in her legs. A month after her first hospitalization, my mom saw a different cardiologist, this time in Boston, and because of a low oxygen saturation, was once again admitted to the hospital. While on diuretics to remove the fluid that caused her swelling, the cardiac unit did a full workup, and on May 17th finally had a definitive diagnosis: cardiac amyloidosis. The light chains that were proliferating due to her myeloma had accumulated in her heart and were leading to heart failure, causing it to stiffen. My mom had to immediately begin treatment for the disease, for multiple myeloma, to slow down the accumulation of light chains in her heart. But it was too late, and she died a month later. What took so long to make the diagnosis of amyloidosis? When an estimated 10 to 15% of patients with multiple myeloma experience symptoms of amyloidosis during the course of their disease, why is it that none of the clinicians on my mom's care team considered this possibility? In hindsight, everything is always so clear, right? The foot pain that she experienced since January, dismissed as tendinitis, the bruising around her eyes in April, the fatigue, the weight loss, the shortness of breath, and possibly even the exponential elevation in her liver enzymes since November could all be explained by amyloidosis. When finally diagnosed, the cardiac amyloidosis expert told my mom that he wouldn't have been surprised if she had had it for years. It could have even explained her carpal tunnel syndrome. Medicine today is getting increasingly specialized. A cancer patient, such as my mom, will be treated by an oncologist, a cardiologist, a pulmonologist, and a PCP at a minimum. To my mom, her inability to sleep and the side effects of the strong medications she was taking to help her sleep was as big a problem as the cancer itself. Each clinician focuses on their very narrow area of medicine, of their expertise, and few have time to think holistically about patients. It's difficult to connect the dots between symptoms presenting over months or years, and it's difficult to figure out which symptoms should be routed to which specialists. This is another area where I believe that artificial intelligence can help. One of my long-term research aims is to create an artificial intelligence agent that serves as a, quote, health coordinator. It'll integrate both patient-provided data and data from electronic health records, reason about the patient's underlying conditions, and then help guide both the patient and their care team towards optimizing the patient's health. In my mom's case, this AI agent would have recognized the early signs of deep vein thrombosis and the eventual pulmonary embolisms. Given these and other symptoms, it would have reasoned that there is a small but non-negligible probability that my mother had an underlying condition of amyloidosis, and it would have reminded both my family and her clinical team to consider this diagnosis. When new symptoms arise, by reasoning about possible explanations in the context of patient's medical history and previously reported symptoms, this AI agent will know which members of the care team to update. By giving a contextual display of relevant patient data and context, the AI agent will make it fast for the clinical team to absorb new information and adjust treatment accordingly. So how do we reach this long-term vision? This long-term vision of creating this AI coordinator. Well, there are a number of short-term challenges that we're going to have to solve, showing how one can use electronic health records to answer basic clinical questions such as, what is the current state of this patient? When will this patient's condition progress? And what treatments should we give this patient? So I'll start out by just giving you a couple of, my whole talk will just be to give you a couple of simple examples of where I've started to look at these questions over the last 7 years in collaboration with a number of phenomenal clinical collaborators. First, I'll tell you about work I've been doing with Dr. Stephen Horng at Beth Israel Deaconess Medical Center. Steve works, he's a clinician, he's an attending in the emergency department. And we already heard today about how there's enormous promise of using AI in the emergency department. The ER is one of the most challenging clinical settings to work in because you have a very small period of time to understand what's going on with the patient, to initiate treatment, and decide on next actions. However, there's an enormous amount of data that we have available on patients. Our goal here is to start asking this question of how do we understand what does a patient have? What is their current clinical condition? And to be clear, this isn't even necessarily to ask a question that attempts to go beyond what the current clinical team knows. We would like to be able to just get to a situation where we know what the clinical team knows, but we have it in some structured form that the computer can act upon. So what we're working on is building what I think is going to be the foundation of the next generation of electronic health records. Algorithms that take as input patient observations such as notes, past diagnosis codes, vital signs, orders, lab tests, uses machine learning and natural language processing to continuously predict in real time hundreds or thousands of clinical state variables that summarize what's going on with the patient. Basic quantities like, are they from a nursing home? Do they have altered mental status? Do they have a cardiac etiology? Do they have an infection? And if we had these structured variables available, then we could build software on top of it. For example, we could build alerts and reminders, decision support, contextual displays, all things like I've been mentioning in the past few minutes. So for example, we could display automatically on the dashboard used by the clinical team suggestions of order sets, such as on the left here, an order set for a psych patient, on the right, an order set for a patient with cardiac etiology. And in order to try to surface these automatically, in order to try to improve clinical care, we have to know, did this patient complain of chest pain? Are they a psych patient? And unfortunately, we don't have this type of data as structured data. And it's not scalable to try to gather all of the data we might need as structured data. Here's another example, continuing with the earlier trend of talking about Ebola. We'd like to know, is this patient at risk of having Ebola? Just 2 years ago, almost every hospital in the world was having a screening procedure to try to assess this the moment patients walk in the door. But we can't use a machine learning approach here, or we don't want to, right? We don't want to wait for the first 20 patients to have Ebola in order to get training data of positive and negative cases in order to predict whether the patient has Ebola. What we'd like to be able to do is to take what we know about the way that Ebola presents and to just build a simple rule into your software. Say, okay, did the patient report fever? Did they have hemorrhage? Did they travel internationally? And if any of these things apply, surface an alert saying, beware, this patient might have Ebola, take the appropriate precautions. But we don't have those elements as structured data. And this is, again, what I'm trying to get at. If we could somehow create these predictions of these clinical state variables, we could use them to build simple software on top of it, such as an Ebola risk screening tool. Now, the previous practice over the last couple of decades in clinical informatics has been to use regular expressions or other simple rules to try to extract such information. For example, if a patient's from a nursing home, you might look to see is the phrase nursing home in the patient's notes. You might look at diagnosis codes or key phrases in radiology reports to try to see does the patient have an active malignancy. And these past approaches, these manual approaches, were time-consuming and they often had very low sensitivity. So for example, you might imagine just looking for the phrase nursing home in clinical notes to see is the patient from a nursing home. And if you did that, what you'd find is that you'd get positive predicted value about 70%. I think it's okay. So you'd find 70% of the people, of the people you predict to be in a nursing home, 70% actually were. But what you find is that the sensitivity is only 18%. And indeed, this is what we find time and time again with these manual-based approaches. So one would have to extend it, maybe come up with some other phrases that might be relevant, maybe nursing facility, nursing care facility, and so on. And after some more manual effort, one would perhaps be able to get a pretty good way of extracting this information from this data for this specific problem in this specific hospital. But then you go to a different hospital, or even different ward of the hospital, and what you find is the algorithms don't generalize because the language is a little bit different and the data is a bit different. And so this effort has to continue. And so this traditional approach never scaled, and it's been one of the main limitations for being able to apply decision support in hospital settings, this scalability, this generalizability problem. So we've been rethinking this problem by asking, is it possible to predict these clinical state variables without ever needing labeled training data? So not doing a purely supervised approach, which would require gathering a lot of data, but at the same time also not wanting to do one of these manual-based approaches that are very slow and don't generalize well between institutions. We developed a very simple approach which combined a bit of domain knowledge for clinicians to specify what I call our anchors, and to use that together with a large amount of unlabeled data from hundreds of thousands of patients, where we don't necessarily know the ground truth for any one of these things. But putting this domain knowledge together with this unlabeled data, we have an algorithm which would allow us to, in an unsupervised fashion, come up with predictive models for all of these clinical state variables. And because it didn't require labeling data, as long as that little bit of domain knowledge generalizes from institution to institution, one could then repeat this process at each new institution. Relearn the model in a way which will immediately generalize well to that institution's data, and thus have a fast, cheap, accurate, and generalizable solution to this core problem. So what are these anchors? An example of an anchor is, well, for a strep throat, you might look for a positive strep test result in the lab tests. For a nursing home, you might look for the phrase, quote, from nursing home in the text data. And here are a few other examples. And in none of these cases can you consider these anchors to be the ground truth for the condition. For example, there are many other ways to write nursing home in a note. There might not have been performed a laboratory test result that could give information about whether the patient has strep throat. We know that diagnosis codes are super noisy. Right, so these are not the same things as the ground truth. But if you use these together with our machine learning algorithms, then you can turn them into high-quality predictions of the things you care about. So for example, when we applied this to trying to understand, does the patient have a cardiac etiology, on the left here I'm showing examples of what were the anchors. They consisted of diagnosis codes for cardiac conditions, and they looked at medications that could be given while the patient's in the hospital as recorded by the Pyxis machine, which is this, in essence, a vending machine for medications that's used in hospitals in the United States. On the right, I show the model that's learned. So of course it recognizes that patients who are older are more likely to have a cardiac etiology. It recognizes that SLB, which in this context means shortness of breath, is predictive of patients having cardiac etiology. And it picks up phrases which are very specific to this individual hospital's language, like CMed, which at this hospital means cardiac medicine. It picks that up automatically and recognizes that that is predictive. So how do you evaluate approaches like this? So what we did is we actually changed the electronic medical record software to try to add a few questions that we could ask prospectively about patients while they were in the ER to try to gather a little bit of ground truth data that we could then use to evaluate whether our unsupervised learning algorithms were doing a good job at predicting the things we thought they were predicting. So for example, here's one of the questions we added to the emergency department dashboard to ask, does the patient have an active malignancy? We ask for an answer in a 5-point Likert scale. We then looked at the predictive accuracy over time. And of course, as new data comes in the patient, you should be able to expect to get better predictive accuracy, and different types of data is more or less predictive. So on the left here, I'm showing a historical condition. We just want to know, is the patient immunosuppressed? On the right, I'm showing an acute condition. We want to know, does the patient currently have pneumonia? The x-axis in both of these plots are time, minutes through the patient's stay in the emergency department. The y-axis is measuring the area under the ROC curve, which is a measure of predictive accuracy. If it's 1, you're doing perfect prediction. If it's 0.5, you're doing random guessing. These blue lines here are the method that I showed you. They require no labeled data in order to predict the quantities that I'm showing you here. Clinicians only specified anchors for these conditions. The green lines are a supervised baseline. For the green lines, we went and we actually gathered data on 5,000 patients for whether they had these conditions or not. And to be clear, you would never ever want to use this approach because it was very time-consuming, it was very expensive, and the models that were learned with that supervised approach don't generalize well between institutions. But it does give us a good point of comparison to see, well, how could we have done compared to that hard approach? And what we found across a wide variety of conditions is that our unsupervised learning approaches actually got competitive performance, in this case a little bit better, but I'm not going to read into that. Let's just say they're ballpark the same as the fully supervised approaches. And that was very encouraging. We could also look to see how did the models change over time, which is quite interesting from a clinical perspective. And you see that the moment the patient walks into the ER, the triage note, the note written by the nurse looking at the symptoms that the patient is saying, the reason why they came to the hospital, is very predictive. Of course, vital signs and age as well. As time goes on, once laboratory test results start coming in, you get things like white blood cell count, which are of course very predictive. That starts playing a much larger role. And then eventually, as the clinicians start writing up their notes about talking about what's going on with the patient, documenting the encounter, which is all done in real time, while the patient's in the hospital, using the electronic medical record, of course that becomes the most important. And so we've applied this approach at this hospital in the emergency department, predicting currently about 40 different conditions, both historical and acute, and it's driving a number of downstream clinical applications. So next I'll spend a couple minutes talking about a different question of understanding when will this patient's condition progress. The work I'll tell you about now is in collaboration with a major health insurer in the United States, one of the Blue Crosses. And we started by looking at type 2 diabetes. In the United States, it's estimated that roughly 25% of people who have type 2 diabetes don't even know that they have it. If you don't know that you have the disease, you're not on treatment, your disease is progressing, eventually you're going to get complications like cardiovascular, cerebrovascular, renal, vision problems, and these complications, of course, lead to poor outcomes for patients. I gave you many examples of that from my mom. And they lead to high cost in the healthcare system. Traditional ways of trying to do risk stratification would look a little bit like this, shown in the right. This is the Finnish Diabetes Association risk assessment form. It asks, what is the patient's age? Are they under 45, between 45 and 54? Each answer gets a number of points, like if they're under 45, it's 0 points. If they're between 45 and 54, it's 2 points, and so on. What is their body mass index? How much activity does the individual have? Have they ever taken antihypertensive medications, and so on? One answers each of these questions. You look at the corresponding points. You add them all up, and you get a total score. Then you look down here, and you say, OK, is your total score between 7 and 11? If so, you're at slightly elevated risk. If your score is over 20, you're at very high risk for having diabetes. Now, what's the problem with using an approach like this? It's a rhetorical question. The problem is that you have to think to do it. Right? So either patients have to go fill out a form like this, or the PCP, the principal primary care physician, should try to fill out a form like this every so often, maybe at the annual physical. But it's not done nearly enough. And so our idea is we're going to do what we're calling population-level risk stratification. We're going to use data that's already collected as part of the practice of medicine, data that's just sitting around in the electronic health record or with the health insurer. And we're going to use machine learning algorithms to try to automatically predict these same quantities. But because this is not perfect data, as I've been trying to allude to throughout today's talk, we don't have many of the elements that I showed in the previous slide. For example, in our data, we don't even have the patient's body mass index. So we're going to need to use machine learning algorithms to find surrogates for these risk factors that would otherwise be missing. And if we could do that, then it would enable running these algorithms behind the scenes for everyone without their even knowing, and then initiating interventions, sometimes very subtle interventions, to try to act upon the predictions. So how do you formulate this as a machine learning problem? Well, here's how we did it. We tried to imagine what would it be like to first deploy this algorithm. When you deploy this algorithm, you're at one point in time, let's say January 1st, 2009, and you want to make predictions at that point in time of who is going to be newly diagnosed with diabetes in the future. You make your predictions, of course, using data. You construct your data using what you know about the patient prior to 2009. And you'd ask a question of what's going to happen to them afterward. And of course, you could ask, well, how much into the future do you want to predict? You could ask what's going to happen to the individual 2 years into the future. Or maybe you want to know not what's going to happen in the immediate future, but what's going to happen 1 to 3 years in the future, which would be this setting, which I'm going to call a 1-year gap model. Or maybe you want to know what's going to happen 2 to 4 years in the future, which would be the setting here. Then we have to show how do we construct a representation of the patient data in order to allow for that type of prediction. And as I've been alluding to all along, clinical data is messy. Here's the example of the data from a hypothetical patient named David. Every so often they get laboratory test results. You know, if there's something that's particularly alarming, you might get some imaging data. There'll be some notes written by the clinical team on the patient. Time will go with almost no data on the patient in between. If the patient happens to be hospitalized, you get a ton of data on the patient at that one point in time. But then they go home and you have very little data on them again, and so on. Okay, so there's a lot of missing data. We're working with multiple timescales, and data is very heterogeneous, lots of different types. So that's one of the challenges that we're going to have to address anytime we want to use AI in a health context. So in our setting, we used a small set of features: medications, service places of where patients have received clinical care, laboratory test results, and so on. And here's how we represented the patient data. We first created a representation which we looked to see which types of places have a patient visited in the last, let's say, in the last time interval. Did they visit an urgent care clinic? Did they have an inpatient encounter? Did they have an outpatient encounter? What types of specialists did the patient see? Did they see a cardiologist? Did they see a rheumatologist, and so on? We looked at the top 1,000 medications, and we just looked at an indicator for did the patient ever take one of these medications, a laxative, metformin, antiarthritics, and so on. For each of the 1,000 most frequent laboratory test results, we looked at, was the test ever administered? Was the result ever low? Was the result ever high? Was the result ever normal? Is the value of the laboratory test result increasing? Is it decreasing? Is it fluctuating? And we also looked to see were any, of 457 of the most common medical procedures, were any of them ever performed for this patient? And of course, when these things happened is just as important as if they happened. So we looked at each of these quantities both in the last 6 months, in the last 24 months, and all of the past history. And we concatenated these different features for each of these different time windows to create overall a 42,000 dimensional representation of what's happened to the patient at this point in time when we're going to make the prediction. One could then use this use these features within that framework I showed you to try to learn a predictive model. And in our case, we had data on roughly 2 million individuals who lived in the Philadelphia area, and we could look from among them who were newly diagnosed with diabetes from, let's say, 2 years into the future, compared to those who were not newly diagnosed, and try to distinguish between them. Here I'm showing you some of the discovered risk factors. Of those 40,000, we found that roughly 770 had some non-trivial contribution in our models. We used a very simple but powerful machine learning method that goes by the name of L1 regularized logistic regression. For the clinicians in the room, you're very familiar with regressions. It's the same idea. We're going to learn a linear model, except, of course, you always worry about overfitting, about generalizability. In order to try to address that problem in machine learning, when we have such large feature sets, we use techniques which are called regularization to prevent ourselves from overfitting by trying to find, in essence, the smallest number of features that are still predictive for the problem. And so these are them. So of course, some most obvious ones come up. Like, for example, if the patient has an impaired fasting glucose, then they're very likely to get diabetes in the future. In this case, it tells us that they're pre-diabetic. Hypertension is predictive. Of course, that's well known as well. Some things which are a little bit more surprising, but for where there's a good story, I'm showing in orange here, like obstructive sleep apnea, shortness of breath, esophageal reflux. These, we think, are examples of where surrogates were found for whether the patient is obese. Obesity was not well recorded in our data. But luckily, because we have so many other indirect, noisy observations about the patient, we're able to put things together to try to figure out that nonetheless the patient might be at risk because of these other signs that were observed. There were a number of other risk factors that came up that were interesting. I'll show you here just some of them, and I encourage you to read our big data paper to learn more details. We then tried to evaluate how this worked. And when you want to evaluate a system like this, you have to think about what is the intervention that you're going to be performing. If the interventions are very expensive, then you might only be able to do them for a small number of patients, maybe even just the top 100 most likely patients. If the interventions are cheaper, you might be able to do them on many more patients, maybe the top 10,000 highest likely patients. And so what we looked at is for different thresholds corresponding to different interventions, what is the positive predictive value? What fraction of patients actually did become diabetic of the ones that were flagging? And we're comparing the models that we learned, shown here in red, with what would traditionally be done by the healthcare community using existing known risk factors that I'm showing in blue. What we find is that these machine learning algorithms that are automatically discovering these surrogates can significantly improve the positive predictive value over the baseline algorithms that just use what's known in the medical literature. So I've applied the same sorts of algorithms not just for early detection of type 2 diabetes, but for many other settings. We applied the same ideas at NYU and New York University Langone Medical Center to try to find patients with heart failure while they're in the hospital so that we can do interventions that will reduce the likelihood that they'll be readmitted to the hospital. For there, we found that using free text data was particularly important. I found the same thing when I worked in the emergency department to try to find patients who are at risk of septic shock, something that, that Suchi, who will be speaking later today, had also done quite a bit of work on. Whereas for sepsis, the traditional ways of identifying sepsis look at a small number of criteria, search criteria, which are structured. What we found is that by adding the unstructured clinical data in, we get a much, much richer view of the context for the patient. And that context is what makes your algorithms so much better. So now I'll move on to the last of the short-term challenges that I think we need to solve in order to reach some of these long-term goals I was alluding to in the beginning of my talk. What treatment will work best for this patient? So here's an example of one of the new types of data that we should expect to be getting over the next several years. This is from expansion pathology. It's a new type of pathology where you take a sample and rather than just looking at your typical H&S stain, you're going to look on a per cellular basis. You could look at a number of different, the expression of individual factors to really understand, localize where different proteins are being expressed within the sample. And the idea is with new data like this, with genetic data as well, with high-dimensional data of the sort I was showing you earlier from the EHR, we might be able to understand that patients, we might be able to predict how patients will respond differently to treatment. And we might be able to use that then to personalize treatment, just like I was alluding to what I was hoping to do for my mother for her multiple myeloma cancer. So the goal here is to use data from other patients and their journeys to guide future treatment decisions. But what could go wrong if we just, for example, used a naive machine learning approach of trying to predict what treatments people actually got in the past? So for example, suppose we did the following. We looked to see David got treatment A, John got treatment B, Juana got treatment A, and then we might say, okay, we'll learn a model to predict which treatment each individual got, and we could then use it for new patients. I hope all of you are wondering, wait a second, well, that doesn't make sense. And one of the reasons why that doesn't make sense is because I've been suggesting that you would want to do this in settings where we don't know very well how to personalize treatment today. Right? So if today's medical practice is nothing other than flipping a coin in some situations, then the best our algorithms will be able to do if our goal is to mimic that is also flipping a coin. So we need to rethink how to formulate the machine learning problem. And the way to rethink how to formulate the machine learning problem here is to bring in the notions of causality, to recognize that really what we want to solve is a causal inference problem from observational data. Where we want to try to find variability within the data, think about how does the treatment affect the outcome, right? So the story I showed here, I only had the input and the treatment. I didn't have outcome. But in order to ask the right question, you need all three: individual, treatments, and outcomes, and to look at the causal effect of the treatments on the outcomes in order to try to optimize the treatments. And this is really challenging to do from existing health record data because it's biased. And here's an example of what I mean by bias. Right? So here we just have a single patient covariate, their age on the x-axis, and the y, the outcome we might be interested in might be their blood pressure. And you might ask, how do different hypertensive medications control patients' blood pressure? Now, if in your data set, and the question we would like to actually ask, we would like to be able to say for each individual, let's say young people and old people, we would like to be able to look at what would happen if they got treatment 1, which is this curve in the top. So let's say the blood pressure 2 months into the future if they got treatment 1, versus what would happen if they got treatment 0, which is this curve in the very bottom. If you look at the difference between these two curves, that gives you the individual treatment effect. And it gives you a sense of, if you were to do treatment 1 versus treatment 0 for that individual, which one would work better. Now, we'd like to be able to estimate that difference from the data, but the problem is that there's bias in who got what treatment. So for example, here we see that patients who received treatment 1 were much older than patients who received treatment 0. And if we want to try to use machine learning in these settings, we have to come up with algorithms to get rid of this bias. And this is a problem that the statistics community, the economics community, the political science communities, and the biostats communities have been studying for decades. But they've been studying it in the setting of small numbers of covariates or features. And so the key challenge that our community needs to think about is how do we get these algorithms to work well now in the high-dimensional settings, the settings that I've been alluding to over the last few minutes. And so together with actually Uri Shalit sitting over there, we've been thinking about how to use machine learning for these problems. We've developed answers to the questions of, well, what should your machine learning objective function be? How should you regularize your machine learning algorithm when your goal is doing causal inference? And we developed a novel deep learning algorithm which can work with high-dimensional data, yet address these issues of bias due to the data that was actually observed. I won't go into this more now, but I just want to allude to this as one of the exciting directions for machine learning in this space. So it's a really exciting time for artificial intelligence in healthcare, but there are a lot of hard challenges to solve, as I hope I convinced you of today. In the last 3 minutes, I know I'm running a bit late, but in the last 3 minutes, I'd like to close with some recommendations for the Rambam Technion program, which I'm extremely excited about. Recommendation number 1, and by the way, these recommendations come from the last 8 years working with data science teams at a number of different hospitals and healthcare providers. So the first recommendation is create a data science dream team. All right, think back to that example I gave in the very beginning of wanting to use data to try to choose treatments for multiple myeloma. And remember what I said about what was so hard of even just finding the treatments in the data, characterizing different treatment strategies, figuring out what are the outcomes before we can even think about how to use machine learning. That requires software engineering. It doesn't require machine learning, it requires software engineering. And you need good teams to do it. Spend the money, invest in those teams here. Second, consider using a common data model. There's been a worldwide effort now to standardize the way that healthcare can be encoded. For example, the Odyssey initiative has created a common data model called OMOP, where medications, outcomes, all sorts of different criteria are standardized in a way that you can write your algorithms once here in Rambam and then apply them in other institutions around the world with just a click of a button. But in order to have that type of generalizability, you need your data in the right same standardized format. In the same way that you can generalize your algorithm from here to elsewhere, you will be able to bring in tools from other places as well if you have your data in this common data format. Third, use clinical notes. Too often have I encountered colleagues, collaborators, who say, you know what, we'll start just from structured clinical data because it gets around really tough problems of de-identification. It gets around hard problems of getting the data in the right place. But you're missing most of the signal there, because clinical notes provide important context about the patient's status, context which I believe is essential in order to get good algorithms. Have an audit trail enabling time travel. For example, if all you knew were the final notes written by clinicians, let's say at the end of a patient's stay in the hospital, then you'll never be able to ask the retrospective question of what your algorithms could have predicted at the time the patient entered the hospital, because you don't have that ability to go back in time. So keep track of all of your data as it gets changed over time so that when you build your machine learning algorithms, you can go back in time and look at those questions. Build hooks into your electronic medical record. You need the ability to get data out in real time so that you can not just do retrospective studies, but so you could then implement your algorithms in order to make real-time interventions. Build tools in order to get those interventions back into your electronic medical record. Again, this is software engineering. I heard that you have your own electronic medical record here. That's a huge opportunity. Take advantage of that opportunity to build hooks so that you can change the way that data is presented to your clinicians. Allow for prospective data collection within your electronic medical record. I gave you an example of how we gathered ground truth labeled data by adding a question to the disposition screen used in the emergency department. That was critical for us to be able to evaluate our algorithms. It's critical because going back in time to do chart review is hard. It's, because you don't really know what happened to the patient at that time. Paying research assistants to be there standing by and gathering data is expensive. And there are ways around that by doing this. Enable fast experimentation. I found that iteration is essential not for solving these hard AI algorithmic challenges, but even for figuring out what is the right problem to solve. You need to be able to start trying something, implement it, see what happens, and then you'll probably realize you're solving the wrong problem. You'll change your problem. You'll go back to the machine learning table, come up with a new algorithm, try it out again. Make sure you start from the perspective of having this quick iteration. In order to do that, of course, you need to remove roadblocks to doing that iteration. For example, very slow IRB approvals. See if you can try to reduce these roadblocks for quality improvement efforts or for shadow studies where you're not actually changing clinical care, but you're still running algorithms in real time, and you can have, let's say, a trusted member of your clinical team look at the algorithm and tell you, do they make sense in the context of the patients in front of you? And finally, create an advisory board for prioritizing pilot studies which require financial resources. And fund those pilot studies, because without them, we're not going to know what are the right challenges to solve. All right, that's it. Thank you.